what I want to do today with our panel is to talk about the business of direct primary care. And to start, I want to rewind about 10 years ago when I met somebody who changed my life forever. I was in med school. I was a first or second year med student. And dutifully, I showed up for my precepting with my attending. We'd coordinated schedules, and I show up in my short coat, and I'm eager. And I am told that my attending is not present that day. She was important. She was doing something. And so I get foisted onto this third-year resident. And it was an absolute foisting because this guy was crazy and he was completely burnt out. Absolutely burnt out. And so I'm like this, little med student, like doing my thing, and this guy, he's like, it's a family medicine residency, right? So I know that we had to have seen, 10 people in that half session that I was there. I have no memory of seeing any patients because the only memory I have of this interaction is this resident, and I'm gonna walk away from the microphone, but you can imagine I'm talking to myself right now, okay? Like this. So he's like yelling, and he's saying things, and he's saying all these things. And he's complaining because he's like 99213s and 99214s and the review of systems, and this is all just garbage, and I can't believe this, and like this is so stupid, and I have to check these boxes, and I don't like checking these boxes, and I didn't even do the smoking cessation, but I'm checking these boxes. It's like on and on and on. I'm just like totally weirded out by this guy. And he must have, I don't think he actually was talking to me the whole morning. I think he was more just talking, and I was in his presence. Because I don't think he even looked at me throughout the entire interaction. But at a certain point, he takes a breath, and I'm like, oh, this is my moment. I'm going to say something to him. And I was like, you're going to have to get used to this, because this is the way it is. Right? I'm like, so smart. Got a lot of wisdom. And he like stops, and he's like, excuse me? And I was like, oh shit, this is the moment. Like as a student in the hierarchy, like I have attracted the attention of like the vulture, and I'm about to get eaten or something. I don't think vultures, anyway, it doesn't matter. Feeling very vulnerable. And he's like, no, it does not have to be this way. I'm gonna open up my own practice, and I'm gonna do it. And he told me where he's gonna do it, and it was my hometown. So I was like, this is interesting. He's like, I'm gonna open up a practice where I don't take insurance. And my wife is a pharmacist, so she's gonna help me do medicine and stuff like that. And it's gonna be better, and it's not gonna be anything like this. It's gonna be different. And so then I felt really, 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 really sorry for him because he was completely delusional. He was crazy, and he was burnt out, and he was delusional. And I was like, oh, you poor thing. So he got all my pity, and I was like, wow, what a terrible morning. So glad this is over. I'm going back to my studies where I learned about like genetics or something. Anyway, time goes on. I matched into a residency program. My dream residency was an FQHC in Denver, and serving the underserved. And about halfway through my second year, I'm realizing that I'm pretty angry about 99213s and 99214s and the review systems and checking boxes, and I'm stomping around my clinic, like, doing this thing and just complaining to anybody who will listen, or maybe even not listen, just talking at people. And I was like, oh my God, I'm turning into that guy that I shadowed back in, I was like, oh God, this is terrible. But thank God for the internet, because I was able to stalk him and I was able to find him. Mostly because I remembered like my hometown and kind of the concept. And so I had an elective to plan, and I was like, oh God, like we were getting married during the elective month, and we were going back to my hometown, so like sort of for my honeymoon, I was like, can I shadow at your clinic? So I got married and then did spend, the week after my wedding at this clinic. It's medical training, it screws you up, it makes you weird. Anyway, the second I walked in, his entire world was different. From the colors on the wall, like beautiful bold colors and olive greens and deep blues, and his nurse greeted me by name. She was expecting me. Nobody was in the waiting room, but he was busy, and so she said, Dr. Newhoffel will be with you in a second. Take a cup of coffee, and I did. And I was like, oh, this is very calm. And as we all know, Ryan is actually not a calm person, so that was just his normal. But I spent the week with him, and I was like, this is interesting. Like, I think maybe I could do this. And then I went back to Denver, and I shadowed with Lisa Davidson and Clint Flanagan and sort of those guys kind of along the Front Range. And at the end of my month, Lisa looks at me, and she was like, you know, I think you could do this. I think, you know, I think you're smart enough. I think you can do this, but I think you're going to get scared. And I was like, excuse me? I was like, I am a type A gunner. Like, I do not get scared. Like, I do things. And so that was all I needed to basically say, like, oh, I will show her. Like, I'm doing this DPC. I got this. And I didn't look back. And what's interesting is that from those moments that I had as a resident in my second year and shadowing with these really, really great doctors, this movement has grown, and it's grown a lot. The longer you kind of hang around in DPC circles, the more you hear people talk about the idea of, can DPC scale? Can this model scale? And I always think that's such a weird question. I mean, it's fine, it's a business question, but it's not like we're like writing software that we're gonna deploy out to like tens of thousands of people and make bank. Like, that's not what we do. What we've discovered in direct primary care is that the most elemental part of being a physician is that relationship with another human. So when somebody says, how do we scale a really, really important relationship with another human, I'm like, I think you're missing the point. Like, that's not it. Because this is scaling in DPC. This is scale. I don't know if you know this yet, but if you are in this room and you are thinking about direct primary care, you're actually kind of sort of thinking about opening up a small business. Like, you're thinking about becoming a business owner. And if we can empower physicians to become small business owners and to go and hang a shingle and succeed and support one another, that's how we scale. We continue to build little clinics nationwide that support that human relationship. That's scaling. So, you guys are all very smart doctors. Actually, we all just stood up, so I'm not going to make you guys stand up again. But can I get a show of hands as to who is DPC curious, no formal plans, no leases signed, haven't incorporated, all this stuff? Show of hands here. Okay, curious. Who here is like incorporated, logoed, got the domain, looking at real estate, getting close? You guys are awesome. You are so close. Big round. Who here is open? Awesome. This is awesome. Okay, no, hands up. No, we're not done. Come on. No. Okay, keep your hand up if you have been open for 6 months. For a year. Very cool. For 2 years. For 3 years. 4, 5, 6, 1, 2, 3, 4, 7. Who we got left? Josh and Lee? That's awesome. I can't see that. Oh, Ryan. Doesn't matter. Ryan's always doing crazy stuff, indoctrinating residents and stuff. So looking around, the people who are open are your network. They're your people. They are how we scale the movement. Rely on the people around you, because you guys are all smart doctors. I know that. Great. You can take standardized tests and pass boards, whatever. You might not actually be a good business person. I'm sorry. Dr. Wade Casey yesterday was so powerful in standing up here and explaining explicitly how he was not a good business person. So take those nuggets and learn from them. It's important. But more important is to stand together as we develop a movement. We're more powerful together. And I think that'll be echoed in kind of what we talk about today. But regardless, if we're going to scale, if we're going to grow, we have to be good business people. So we're going to do something along the lines of what's called a mastermind. I'm part of a breakfast group that meets every other Thursday morning, varied industries, and we all sit around and we discuss every other week we discuss a struggle and we deconstruct it. we discuss a win and we deconstruct it, with the idea being that if we can get it down to the atomic parts as to what made that a win or what made that a struggle, we can all learn and be better. So we're going to do a little bit of that today in the hopes that we can all raise each other up and be amazing business people. So I'm hopefully not going to talk at all for the rest of this because we have an amazing group of panelists, and I'm going to have you guys all introduce yourselves. Name, where you are, like your location, practice size, style, partners, maybe your target demographic, who you go after, and that is it. That's it. Okay.
Hi there. I'm Amy Ostick. I'm located in LA, in Los Angeles. I've been open for 10 weeks, so I'm brand spanking new, and so this is my second year being here. I've just absolutely been bit by the DPC bug. It's very infectious, and these are the happiest group of docs, happiest convention I've ever been to. So I have 100 patients. I started with 35. I was in the HMO world for a long time, and then most recently with UCLA, burned some. It was not a very amicable separation there, but that's okay. I had a lot. You guys really helped me. I hope you realize that through the Facebook group and just reaching out, kind of really go walk through that carefully and supported me and said it's going to be okay. You're going to ruffle some feathers. So I have 100 patients. My target demographic is moms. I just go after the moms. Awesome. Those are my people. I have 3 kids, so I'm in a lot of mom groups, and they really do make the healthcare decisions for the family. So that's been my.
And who's in the office with you?
Sorry?
Who's in the office with you?
Oh, I have an MA. Yeah.
Very good. Okay, cool.
So my name is Emily Scott, and I'm here with my husband, James. And we have a practice called Halcyon Health in Irvine, California, so we're neighbors. And we've been open since 2016, and we have about 900 patients now. And before we started our DPC, I was working for an academic institution for a while, and then working for Optum Health. And I don't know if you guys are familiar with Optum, but they're owned by United Health Group. And found a lot of struggle with that as far as how there's so much conflict of interest between what happens in that type of practice and what our patients really need. So having our DPC has been really opening us up to really caring for our patients in the ways that we always want to as physicians. So.
Hi, I'm her husband. I'm a recovering emergency medicine physician. I no longer practice emergency medicine. I have a small panel of DPC patients as well. We stumbled upon this probably 5 years ago or so at conferences like this, and have been very grateful for the mentorship of many of the people before us, so thank you very much. And we are very grateful for that and would like to do the same for others. And I think that's important to grow the movement. For me, direct primary care is the ultimate intersection of art and science. The art of medicine has been lost. We are now checkbox clickers, as a lot of us have alluded to in our careers. And I think it's really time for physicians to take back the field of medicine. And so the art of medicine is how we scale. It's the people. It's what I have fun with on a personal level with patients and dealing with other physicians and just getting people to know more about DPC. So thank you for having us here.
What does your office look like?
What's that?
We have 2 MAs that work with us, and we're hiring our 3rd physician in January and expanding our office to twice the size. So.
Dang, that's impressive.
Awesome.
Sounds expensive.
Hi, I'm Donna Givens. I'm in Grants Pass, Oregon, which is southern Oregon. I, in 2013, wanted to get out of the employed physician situation, so I opened a solo practice, but it was insurance-based practice. I didn't quite know about DPC at that time, and it grew and was successful, but in 2017, January, I sent letters out to all those patients and told them I was converting the whole practice to DPC. So as of April 17, when I started that, we had 215 patients pre-enrolled, and it just grew from there. I did a little bit of a hybrid situation for a little over a year and was still participating in a Medicaid managed care plan. That was the only insurance contract I kept for about a year. And then after that, now I'm just pure DPC. So currently at about 535 patients, I have 13 companies and 60% of my practice is uninsured. So we serve an area that our county is about 80,000 people. It's considered rural there, and 33% of the county is on Medicaid. But we have just above that income level is this big gap of people who don't qualify for any Medicaid, or their employer can't afford to provide health insurance. So we've really tapped into that population. I feel like I've reached people who have not had care in many, many years because they couldn't afford it. So it's been very rewarding. We have a big demand, though, for primary care physicians in our area. So I have an LPN who works with me in the back part-time, and then a receptionist up front, and my husband who helps tremendously with the practice every day as well. So we have now decided, because of a waiting list and because of another arrangement with the county employees, that it was time to expand a little bit. So Dr. Tamara Powell's going to be joining me in January, and she's been practicing in Grants Pass for over 20 years, so I'm really excited to have her join me, and she has 40 of her own patients pre-enrolled already, so
That's amazing.
that's where we are.
My name is Brandon Allman. I'm one of the co-owners of Antioch Med in Wichita, Kansas. And my kind of path to DPC started very early. So I entered medical school thinking I knew a lot about how healthcare should work, and exited medical school thinking there's no way I'm participating in that system. So I picked a residency that would train me broadly without knowing that Kansas was the hotbed of DPC. So entered family medicine knowing I wanted to own a business. I opened the practice with Nicholas Thompson, who many of you probably know. During my second year, I actually proposed DPC to him as he was trying to figure out what was next for him, and he thought that was a really stupid idea. If you know him now, you know that he's one of the most vocal advocates of how DPC can be used for lots of different things. So he actually started taking patients while I started my third year of residency. I joined seeing patients full-time after residency. The target of who we thought we were going to get, we thought we were only going to get uninsured patients. That's what we thought was going to happen. It's grown to still serving uninsured patients, but also serving individual patients, and then we take care of a couple dozen small businesses at this point. Our vision going in, we thought it would be the two of us, but that's changed recently. So we hired our third physician in February of this year. We have our fourth physician starting in January of next year, and then actually offered a contract to a resident to start in August of next year as well. So we're having to expand our clinic for a second time. We have 2 full-time RNs and a couple kind of part-time staff as well. So our vision's changed, but it's been a really exciting journey.
Very good. Thank you, guys. So you can see they're all struggling tremendously. So that's what we're going to start with. I know we're a little bit short on time, so I had some fun little icebreaker questions I'm totally not going to ask. And we're going to go dive right into how much you guys are all struggling. No, the idea of a mastermind is truly to get help from your peers and to really think through a problem, and again, pare it down so that we can all kind of take something away from it. And so, I mean, when we were talking about kind of wins and struggles preparing for this, I think that you raised one that was incredibly poignant and resonated with everybody through each stage of growth, if you want to share.
Yeah, money or lack thereof. And so that's really my struggle right now. We're obviously in a losing red zone, and getting the red confirmed, unconfirmed enrollments thing in my atlas is like Christmas. When I see that, I'm like, somebody signed up. So, we live in a very high cost of living area in Los Angeles. We have 3 kids that are all in Catholic school. We got my husband and I, my husband's here, he's an ER doc. And we got very used to, about 8 years out of residency, about 9, very used to a 2-income family, and developed our household based on both of us working full-time jobs. And it's, have a mortgage, and like I mentioned, a lot of very active kids. So it was a huge, and then it was a huge decision to decide we're going to live on 1 income, and we're not going to contribute to retirement this year, and we won't be doing that. There were a lot of frivolous things that we had to cut out, but every month it's a new discussion, and it's hard. I carry a lot of guilt with that, but I just work my CBT that I learned in medical school, and we work through that together. But I'll mention, that is a struggle. It's daily, and it's every month we go through our budget to see how we can improve. And he's made a lot of sacrifices and poured a lot of his salary into the practice, the setup. But we paid off. We had $550,000 of student loans coming out of medical school combined, and I think I'll just say this to kind of end on a positive. We paid that off in 5.5 years through Dave Ramsey. Dave Ramsey showed us the way. And there is no way I would have ever taken this jump if we were still staring at that in the face, if we were still had that amount of, I just would have felt really trapped. And it would have contributed to even more burnout, I think, that I was feeling when I was within UCLA system. So because we learned earlier on through that process, sort of getting on a budget and being mindful and practicing contentment, within living below our means and all those practices, we had those set in place. I think it made it easier, at least it's not easy, but easier to sort of look at that in the face and say, okay, we can do this, we can take the leap. And we have a plan, and we'll set forth a 3 to 6 and 12-month plan, and then just revisit it. So I think that's just being really frank with our budget and our money has been helpful. But it's scary. Because again, like I said, we went down from 2 to 1 income.
So it sounds like you were incredibly pragmatic about dissecting out. And did you actually make a budget?
Oh yeah. Yes, he's an absolute nerd when it comes to, and now I've become a nerd too with the budget. So we have a personal budget and then a business budget. So I guess how we approached it this time last year was when we sat down at Disney Springs last year and
very
really
budget-friendly
marched
place.
out our
Very
budget, our
budget-friendly.
business plan. And every month we're going to contribute X amount of dollars to hopefully have this sort of seed money. As a startup, we didn't take out any loans. That debt is a bad 4-letter word in our house, so we didn't do any of that. And so we had that money set aside, and exactly, we kind of had an idea of how we were going to spend it and what we needed. So that was helpful.
More established practices, thinking about budget, thinking about debt. You all mentioned growth. And James, I think you said expenses. I think you whispered it into the microphone very, very silently. Tell me, how do you conceptualize budget, debt, finances as a growing practice?
For me, it's all an investment, and you're investing in yourself, you're investing in your life, and you're investing in your career. So clearly you have to have objective goals, and like Amy alluded to, some practicality behind all of that, but you do have to have a vision of where you want to be, where do you see yourself in 5 years, 10 years. There's this higher level, really the fun part of it, in my perspective, of your identity. Like, who are you as a physician, as a spouse, as a father, or whatever it is. I think those things really are important to highlight and plan out, and then you get into the details about what does that mean, and what are the risks you're willing to take. And I love risk. I love calculated risk. It's fun. I get a high out of it.
Good business person right there.
It's kind of fun, right? And luckily, we have a lot of support. If you have questions and there's doubt, we have each other. So I think that's been a huge part of just being able to work through that. So that's how I.
Other thoughts?
I think for us it's been a bit of push and pull because I'm very risk averse and very debt fearful, and he is more open to investing in ourselves and taking those risks. So we have had this push and pull. And for me, the first 3 months of not being in the black were very distressing, and I would look at the bank account every day. And now, almost 4 years into it, I've completely let go of looking at the money because it's going okay. And so it paid off.
Good. Any other thoughts?
Yeah, I think that's our growth. I think the biggest thing for us is letting go. Going from a place where between Nick and I, we could do all of the pieces, and then attending the kind of manager session this morning, realizing that we're going to have to let some pieces go and entrust that to another person. And so figuring out how to make that transition is a struggle. And as you're going through the hiring process, hiring people that match the culture that you've created. And it sounds like, in talking to James and Emily before, that is something they've done really well. And so it's something we're trying to replicate as we're adding people. So maintaining the culture, but also trusting pieces that you've done yourself for years to someone else.
Speak more to that, the culture in office and kind of struggling through.
You guys should comment on that as well, the success you've had.
So once again, I think putting startup in this talk is really great because you treat this as a startup. And so if you study startups and technology and business, I mean, for me, culture is the heart of everything, and whether you're successful or not is really going to be dependent on the culture. Whether you're a solo doc, whether you're a doc with multiple physicians or providers, you really have to be intentional and mindful about what are the qualities and values. And it isn't some big corporate thing that you put on a wall. This is yours, and you own it, and you get to define it. And so sticking to that when all these questions pop up, you're confused, you can always go back to that. And that to me is really the most important thing, I think, for us as we grow, when we started, always sticking to that and refining it as well.
Back to the budget and financial issue.
Donna's been thinking about the budget the whole time.
I think keeping overhead low is probably
Yes.
the most important thing when starting the practice, and then keeping it sustainable. But of course, sometimes you have to take some risk financially, and personally, I'd rather take a little bit of financial risk and be happy with what I'm doing and feel good about what I'm doing rather than make a giant salary and not be happy. So I think it's worth it.
So to recap, budgeting is important. So I think it's fun to have somebody who's fresh, new, and is still super jazzed when the little red, you got an enrollment lights up, because it's very real. Whereas Emily's like, I don't look at the money anymore because it's there, right? So to sort of say this explicitly, you have to plan, you have to budget, you have to be explicit. You really do. You're running a business and you're putting your family through a lot to do this. At the same time, if you keep your budget tight and you look at your expenses and are responsible about this, at a certain point it makes it worth it, and then you get to start to have more creative conversations like, James is talking about, where it's like, ooh, this could be fun, we could take the risk here, et cetera. Each part of doing your DPC practice has a season, and at every moment you're going to have a different need, but there is sort of a current that runs through the entire phase of it. I want to talk about culture a little bit more. I think I know the answer to this because I already asked them, so I'm just asking them a question that I know that we've already prepped talking about. So tell me about culture and how you preserve the culture of your practice style with your patients and with employers as people sort of push you to do perhaps beyond maybe what you want to do. Because I know in fee-for-service, it was very easy to say, whatever, I don't care about, this patient didn't like me, it doesn't matter, I'm just going to get another patient through the door. The mindset changes a little bit. So I think, Emily, you had a really good example.
Yeah, so we, early on when we were in the phase of, oh my gosh, we got another patient, thank God, we had a business approach us and say, we want to sign up our employees with you, and we were so excited about this. And we didn't really know what we were doing. And so over time, as we worked with this business, we learned some big lessons about establishing a clear culture for your practice and how that lines up with the culture of the business that you're aligning with. So what we ran into was the culture of this business was not very health-based. There was a lot of how quickly can you get drugs into my employees so they can get back to work. And the interesting thing was when someone would come and I'd try to really counsel them about maybe you don't need a Z-Pak today. Maybe we can think about something besides Xanax. It got dispelled among the company that I was the doctor that didn't like drugs. And so other people who had never met me and worked at the company would come and sit down and be like, well, I know you're the doctor who doesn't like to prescribe medication, but... And that's not at all how, we're trying, as you guys understand, we're all trying to use drugs appropriately and do the right thing for our patients. So what we really learned from that is we have to set, even though we're so excited to get going with people, and we have since that business, we're not working with them anymore, because over time we realized we don't need to bend over backwards for this that we don't align with. And there was plenty of other business, so it was okay. So when you're starting early on, knowing that you don't have to sacrifice your standards or quality care to be successful, you really can practice the best medicine and still be successful in your practice.
How else have you guys worked with that, toyed with that? Compromised yourself to get a patient? Like, bent over backwards?
I think there's a lot more of a customer service aspect to DPC, and I wasn't used to that. I don't think many of us are trained that way. It doesn't come naturally, but then when you start really getting to know the patients and working with them, understanding each other, I think it just comes naturally. But it is a different relationship. They're paying you, you know that they can leave if they want to and go elsewhere, and it is a little more challenging to navigate their requests versus balancing that with your desire to provide really good service.
Yeah, I think that I have this discussion with patients sometimes, and the analogy is I'm not a vending machine. So what the membership payment is for is because you value my knowledge and my expertise and what I have to say about how I think you can become healthy. If you don't value that, then that's fine. But what you're not paying for is what I can write on a piece of paper or what you have access to through me. And so similar to Emily's statement, some of my first 50 patients were a business, and it was definitely the vending machine scenario. They thought they were going to come in and get these exact things, and that they didn't even have to come in. They could just text me and get those things. And it was really scary as my first few patients to see some of them leave and wonder, like, am I doing this wrong? How's this going to work? But I think not compromising when you're in the growth phase is really important. So you do the medicine that you think is great, and people will value that. So.
Beautiful. Okay, let's talk about wins. So we prepped for this a little bit and kind of put our heads together to talk about wins. And what was, I think, obvious from the way that each of the panelists introduced themselves was that there was an overarching sense that the win in DPC for everybody here is the fact that they've been able to grow. And so if I could have each of you guys share a pearl about how you think your growth has been cultivated. Including, let's start at Brandon, since, by the way, Brandon is having to catch a
Bad
flight.
scheduling, yeah.
Or do you have to leave right now?
No. I'm just saying I scheduled this poorly.
But so if he just walks off the stage, it's because he's actually very angry and he doesn't want to talk to you guys anymore. But anyway, you want to start, hack your growth. What do you think?
Yeah, I think the growth that we said is great, and that's definitely a win. I think one of the unique things about our practice is Nick Thompson has been, if anybody heard us talk about kind of expanding what a family doctor can do, we've kind of been able to bring that back. So our practice, of the first 4 doctors that are joining, we will all be able to do obstetrics. We'll all be able to see our patients in the hospital, and that's just becoming rarer and rarer. So in our county that we practice in, we'll have more family medicine people doing OB than the rest of the county combined, with 4 doctors. And so that's just a success. Both, yes, we've grown in patients, but I think we're also growing in what we can allow doctors to do. So our residency trains people to do that, but a lot of them, either they have to go rural to do it, or they have to accept an employed job that doesn't allow them to do their full scope of practice. So growth on the patient side is great. Growth on what medicine can be for family medicine is something we're also passionate about. So that's been an exciting win for us.
Did you have a recent delivery that was pretty impressive?
Yes, not to tell this story, but yeah, so we have great relationships in town too. So when we were sharing wins, I jokingly said I should talk about the second twin breech extraction I did a couple weeks ago. So that was an exciting win for us. So I had help with that, but it was fun.
Yeah, I thought I was doing well, and then it's like, well, when the second one was breech, and I was like, oh my God, good job. Okay, who else? Growth. Donna?
I think, I guess a win I've enjoyed seeing even just recently is seeing the brand grow. It's really hard to build a brand in probably bigger towns. It's harder, but our town's fairly small, and everybody talks among themselves, and word of mouth is huge. And so to be able to get that positive word out and be able to be recognized as a legitimate brand and attract patients that way has been successful. I'm happy with that.
How did you develop a brand? Like, how do you conceptualize that?
Well,
I think that's kind of a nebulous thought. Like,
I think just having a consistent message, trying to provide that consistent good service, asking people for reviews when they can go online and give us a good review on Google or Yelp, and actually asking them to do that, and then they're able to spread the word to their friends and family a lot faster that way.
Do you actually ask them?
I do. We went through a phase where after every visit, we had a macro set up to email them and ask them for reviews with a link provided, and they did, and it worked great. It upped our stars, and it worked fine. I don't do that with every visit, but it comes
Only
in
the good
phases.
visits. Yeah, the good visits. Yeah.
Yeah, but I train staff on how to do that, so they can do it themselves.
I think it's an important thing is to be active in your brand management and to actually get over yourself and say, like, I actually do. We had somebody came up yesterday to the microphone and said, if I take care of you, tell people that I did it. And I probably just butchered that, so sorry, I apologize. But it has to be an active management, so that's a really good point. James, do you have a brand? How's your growth? Tell me more.
So that's actually our next phase, and intentionally when we had started, it was about Emily at the end of the day. She'd been in the community, she had a great following of patients, the brand was her, and that was just built because we knew that was, in my mind, a very safe bet to be able to market her and have a stable patient panel. Looking forward, the brand now is not just her anymore, it's about our business. And how do we do that? That's the fun part, I think, in terms of creating a story. What does that mean? And that's stuff that I will be working on and am working on now. The growth success for us, really at the end of the day, it's just so fun being able to be yourself. And that sounds incredibly basic, but to be able to go into your own office and feel comfortable with yourself and everybody else in the room and your work environment, your MAs, the patients, they're comfortable, and that's just amazing. And I think that's the gift of DPC, and just to be able to know who you are and be comfortable, and that's been, to me, the little secret sauce, which isn't really very secret, it's just the sauce. It's like ketchup.
Good work on that sauce.
I'm taking the mic away.
That's a good partnership, balance.
One of the things that was interesting was we were growing around me because of my establishment in the community, and now I'm ready to stop growing around me, right? You get to a point where you're ready for someone else to grow your practice a little more. So that's something to think about too, starting out. How is that transition going to be made? Like James was saying, in 5-10 years, what is it going to look like? So we didn't call our practice Emily Scott Practice. We have a different name for our practice so that it doesn't become just all about one physician. And then that puts a lot of burden on that physician. I think the way that we were successful early on with growth is the way you all will be successful is this is not a fair playing field. We have such an advantage being in DPC over everybody else in the community practicing insurance-based care. It is so easy for us to impress our patients just by doing basically what we all should be doing and want to do. So it's not that hard. We just embrace it and we go the extra mile. We actually listen to our patients. We call them back. We answer the phones. Like these super obvious things that it seem like they should be easy, but they're really not for everybody else. And so our marketing just happened word of mouth. People go online and put reviews and people are so happy and that feels really good. So.
How does that feel to hear that, Amy, when you're like just open, and you're like, oh, like word of mouth, like I've only been open 10 weeks. How do you get word of mouth when you've only been open 10 weeks?
I know, and everybody says that our struggle is making that happen. So everyone says they are. I mean, the beauty of it, I see the smiling faces as they leave the door, but just turning that into an action actionable item like a review or whatever, actually having them tell somebody. My win, I think, really is just I love doing medicine again, and I really could cry thinking about how I didn't.
Yeah.
I really hated it. I didn't like it. I didn't like it.
Girl, that's awesome. I have this Kleenex in my back pocket because I was afraid I was going to sneeze, but I haven't yet. So, I think that's beautiful. And it was interesting in this mastermind group that I'm part of. I had a woman who's a counselor who left insurance and started her own practice, and she just stopped and she's like, "Isn't it funny how when you just stop caring about the money, and I know the money matters, and I know that," she's like, "you can be happy again and you can just take good care of people." And it's powerful to just deconstruct and say, like, this is our passion. And when you take good care of people, they start to tell others, they leave reviews. It returns that intrinsic motivation you have to actually do well and to work hard. For the record, I still work a lot. I am not working 30 hours a week and like peacing out at 3 and starting to drink a martini by the poolside with my cigar. Like that is not DPC. Just in case somebody's like, "Oh, this is great, I'm only gonna see 8 patients a day, I'm gonna be out, it's gonna be fine." I still work really, really hard. I'm a small business owner and I'm a physician, and I take patients home with me and I make mistakes and I make patients angry and I have to like apologize. Like, we work hard. We work really hard, but we do it because we're passionate about it. And I think, Amy, you just exemplified that so perfectly. It means a lot. We are gonna take audience questions. I think there's something on Twitter called like #AMA, which doesn't stand for American Medical Association. I think it stands for Ask Me Anything. So like, I'm gonna put the panelists up here where you can just ask them anything. Try and keep it pleasant, maybe PG rated, things like that.
Or not.
Or not, or not. But I think that, and I was saying this to Lee kind of when I pitched this idea, was that some of the most powerful moments coming out of these conferences, I think, are the opportunities that we have to talk to one another and to ask questions and to bring up the things that we all struggle with. And so if there are anything out there that you guys have that you want to make sure that you get asked or that you want to ask in a public forum, or if you want to do that thing where instead of asking a question, you just talk a lot about yourself and how good you are, you can do that too. Because you are awesome and you deserve it. Anyway. Okay, I have a few more questions that we'll kind of go through and please do if you want to ask questions. If not, Brandon will take you to the airport with him. There was one thing, Brandon, that I'm going to ask you a question. I'm sorry. If you need to leave, please do.
Nope, I got it.
There was something that you mentioned when we were talking about how much, I don't know if you said easier, but how much more knowledgeable your community is about direct primary care now versus when you first started. Where does that come from, besides Josh?
Yeah, Atlas has been a great help in that. So, but yeah, even in the 3.5 years we've been open, it's gone from when we opened, you had to explain to every patient and every employer and everything what direct primary care was, how you were different, how you worked, how that was going to work with theirs, and now it's people coming to us. So it's brokers coming to us, it's in businesses coming to us. It's they already know, okay, we got this concept, you guys are doing it right. How do we fix this stuff over here and work with you, because they see the value. Please talk about what we did with a self-insured business. Like, that's the opportunity that people want to now create, and we're the, DPC is the backbone of it. And so that's been exciting. I can't take credit for that alone by any means, but it's been cool to see in our community.
Nice. Do you feel like you have a fairly collaborative environment in your city in which you work, where kind of as a unit you guys all raise each other up?
Yeah, people ask me that all the time. So I think there are more than 10 DPC physicians currently in our city. And people always ask us, "Oh, they're your competition, right?" And I was like, there are 600,000 people in Wichita. Like, we have 10 physicians. Like, the bad system, that's who we're competing against. So in no way do we feel like threatened by other DPCs opens. We try to help other DPCs open in our town if they want to. So I don't feel that at all, as in an area with a pretty high per capita rate of DPC physicians.
Nice. Have you guys collaborated with people nearby? I mean, I realize that we have neighbors here. How'd that work out, kind of as like a support structure within the area?
I mean, they were amazing. I mean, just a year ago, I think we drove down. Now it's, 6 miles, 13 miles away, but it's like 3 hours, so it's really not close. So it didn't seem, and I'm technically the only known pure DPC office in LA County, so, which is crazy. I'm in a small suburb of 3 million people, so, you know.
Watch
so
out for
there's
competition.
I know,
Yeah.
what competition? It's just it's a very Kaiser-run area, lots of HMOs, and a lot of concierge. So I think the biggest struggle for me in the beginning was, or still, right now, is distinguishing myself from concierge, because they're like, my concierge colleagues are like, you're charging what? My rate's like $5,000 a month, for crazy. So that's been a real interesting conversation. I think you feel like people think you're cheap, and there's, why are you so cheap, and what's wrong with you? Like, did you get fired from UCLA? Anyway.
Is that bad?
Yeah. So,
No.
No, they were great. A year ago, I drove down to their office, and it's just, you know right away that, this is where you want to be, who you want to emulate. This is the type of practice that you would like to have, that you see the smiles on the whole staff's face, and the fact that the staff is so happy is incredible. It says so much too, because so many doctors' office staff are so miserable.
Yes.
So I think it speaks to just the culture there, but yeah.
Good job.
They're very helpful.
Yes, ma'am, I think. I can't see very well.
Hey, I'm Rachel Shear. I have a DPC that's been open in Florida for just over a year.
Yay,
my question's kind of financial related. A lot of us have left employed jobs and huge financial sacrifices like you've already discussed. We just started paying ourselves, although my nurse makes more than I do. So I have moonlighting on the side. And I think we plan that in the next 2 or 3 years, if our growth continues, then hopefully I'll be paying myself close to what I made in the past. But I think for a lot of us, we want to know that, even if we're not making as much as we did working for the big systems, we're going to be making more than our nurses. So for those of you that are expanding and growing, have been open for a while, you don't have to say specific numbers, but are you guys closer to those people that are employed? How's the financial parts working out for you?
Great question. You want to start at that end, Brandon? How do you?
Yeah, I think the growth phase is hard. So I moonlit in rural ERs for the first year and a half that I started taking patients, and it's not easy. We're still paying ourselves back from stuff we feel like we earned even 3.5 years ago. So, but there is light at the end of the tunnel. I think the budgeting that was mentioned before is really important. So these aren't, you can calculate what you can make, and you just have to kind of justify that membership price, and it will work out in the end. I think going from me downloading the billing report every month and going through it line by line to what Emily said, that the money's going to be there, it is a reality if you keep going.
So instead of moonlighting, I had that cushion of having one contract and running the practice as a hybrid for a little while. So it worked out fine. I make less now than I did in fee-for-service, but it's not drastically less, and it's perfectly fine with me. So it's sustainable, and it was not a huge hit. For those of you who are in private practice, there might be some other ways to do that, whether it be moonlighting or veterans exams, or Neil outlined some of those upstairs today that you can do on the side to help cushion that transition time.
Yeah, the short answer is yes. You can achieve, I think, the numbers. I think it's really important to reverse engineer, really answer some hard questions. What does your lifestyle cost, and what is it going to take to make that? And you start backwards and say, these are the expenses, and once again, you have faith, and you can look at your growth rate, and looking line item by line item like Brandon did in the beginning. Is it going to, when are you going to potentially reach that point? So short answer is yes. You can make as much or as little as you want, to be honest. You change the price points. It varies by market in terms of what the demand is and who your patients are, but I think the short answer is yes, you can make whatever you want.
I'm making more than I did as an employed physician now, because there was no way I was going to work full time in that system, just no way. So I was 60% time, and now I'm probably making as much as the full-time docs in that practice did, and my life is way more joyful. So.
Totally.
I make 0. Negative.
It's okay. You call us anytime you need to, honey. I started paying myself a graduated wage, so as we earn more and more, we raised it. And then I sort of got stuck at like 50,000 just out of sheer laziness, and realized that I drive a 2000 Honda Accord, and the paint is peeling off, which I think makes it look awesome. But thank you. It also has a dent in the door, but that wasn't my fault. But anyway, so the point is, like, we kind of stuck there, and then finally my husband was like, you realize that we can actually pay you more. And then I had this thought, I was like, well, I kind of want to grow the business, so me taking it out in wages, and there's all sort of tax implications and things like that, but you can. For a while, my nurse was making more than me, but at the same time, she deserved that. So, and we have a business plan moving forward and whatnot that we need to support. So, I think James's point is correct, that you play the numbers and you do well and you take good care of people, and you will grow and you will pay yourself potentially more than in fee-for-service. Go ahead.
So something I haven't heard touch base on at all this week, is, in theory, with better care, we're spending less time sending our patients to the hospital or specialists and things like that. How have you worked with hospitals and developed collaborations with hospitals and with specialists that they feel is mutually beneficial, particularly like hospitals?
I think you probably have the clearest relationship with the hospital. Brandon? It was kind of hard because it was a little bit echoey.
Yeah, just wondering about how you developed relationships with the hospital, and so if for people who have hospital privileges or however that works, if you admit yourself, or also just other specialists getting support, or being teammates with other specialists in the area that you may want to use, rather than feeling like you're taking away from them. So it's mutually beneficial.
Got it. Hospitals.
I think that's the second wave. So the core behind direct primary care is transparency. And so we give transparency of price in primary care. And we do if you're a great doctor doing that, you're going to take care of people well, and the savings will happen down the road. I think spreading that in your local community is a great thing to do. So getting the specialists that you refer to on board, I think that's something we're trying to do in the next year to get them to understand the concept. And not just, hey, this is a special relationship with us so that my patients can get this price, but this is good for them too. So they are fighting the same battles. I talked to a specialist in town where there are more coders than specialists in their office. And so them being able to get out of that system is important as well.
How did you get your hospital privileges? I think that's very unique.
Coming out of residency, it was easy because all my numbers are recorded from the hospital system. So I actually went to both hospital systems in town and said, hey, here are my numbers, and could do it. So I think that might not be a great example for everybody, but that was easy for me. I think if you can get in with the physician rep with the hospital, they will walk you through the process if you want to take on something new, having you proctored. So some of the people that are coming back on and are wanting to redo obstetrics with us, we can work with the community to get them re-privileged in things that maybe they haven't done in a couple of years. So people want to talk to doctors. Somebody, Neil was saying in the last session, you have the most powerful degree there is. So if you have a physician, people want to work with you and want to make things work. So being open to those conversations is kind of how we've maintained those privileges.
Does anybody else have hospital privileges? No. Do you?
So, I'm credentialed at a hospital, but it's social limited. I mean, I could have done full blown, but I didn't think I would make the volume. I think you have to have volume to keep the credentialing, but I wanted it for Epic access.
Yeah, girl. Totally. And then on the specialist side of the question, I know, at least speaking for the Kansas City market, we have a shared Google Drive folder where we put all the pricing quotes that we get from the specialists in the area. So you can kind of go on and, type in cardiology, and you can see, Echo 400 from this, vendor. And so in a collaborative way, we share our pricing. And then we actually got that Echo price because, I don't know if it was you, Lee, somebody in South Carolina had a cardiologist doing echoes for $400 that we found out about. So we took that price from South Carolina and said, can you guys match this? And they did. And so sort of that collaborative bargaining. And the fact that if you do the math, I think we represent, and our DPC offices represent about 9,000 patients in the Kansas City area. That starts to make people pay attention. What you got?
I'm noticing that functional medicine is becoming more and more in demand to consumers. So how do you guys feel about incorporating functional medicine into your practices?
I don't. There's plenty of functional docs in LA. Trust me, they're all doing it. So I would have to get trained on that if I really wanted to. So I don't think it would distinguish me, actually, because I think what distinguishes me is really the access and the small panel and the quality of care. So, but there's a lot of functional docs.
I agree completely with what she just said.
I actually want to get certified and then do the exact same care that I'm already doing is my plan that I joke about with Nick. But maybe smile more when I do that. So no, we aren't doing any of that currently.
You could just market yourself as a functional doctor.
Exactly. Yes. Yep.
Okay.
I don't have any plans either to include functional medicine and spend so much time on just the bread and butter of family medicine, and it's just not an interest of mine. So.
All right.
I'm going to take off. It's not because I'm angry, but thank you everyone for listening to this.
Thank you.
Brandon?
Let's see. I'm sorry, I didn't see you standing there. I don't know how long you've been there, but if you have a question, please share.
Hi, I know only one of you is from a kind of a semi-rural area, but I'm going to be opening my practice actually fairly close to you, Donna, on the coast. And I wonder about doing telehealth with specialty care that you can offer in your office. I'm not sure if anyone has heard of different companies you could potentially contract with, or if anyone's used teleconsults with specialty care, but it's such an underserved area for specialists where I live. I'm just wondering if that could be an added value that you can contract with for patients.
That would be awesome. If you know of something like that, I would love to find out about it.
So we do that. We do that. We're not in a rural area, but we use a telehealth service, and I use it a lot. Because I'll get an EKG and I just want to be sure and I have that extra time, or the patient just wants more reassurance about something. I send pictures to the dermatologist. I've been able to manage melanomas, things that I wouldn't otherwise do because I've had this telehealth support. So even in an urban area with very high resources, if it's $1,200 for their excision of their skin cancer, at the derm, and $50 with me, they're going to come do it with me. So,
are you allowed to share that resource, what it is?
After the panel, you are welcome to ask. Yes, very good.
Just like to know what the main reason was for each one of the members on the panel to make the leap to DCP.
Perfect ending question. What is your DPC moment that you decided this is what you needed to do? What was that domino that fell? Okay, Emily, you raise your hand. You can go first.
So Medicare Advantage high-risk billing. Do you guys know this? I was told in my practice that I had to do all of these tests on my Medicare Advantage patients so I could increase their RAF scores by getting more diagnostic codes so that they could get more money. And I couldn't opt out. I could just leave if I didn't want to do it. And so I said, bye. Seriously?
And then she made me do it after that.
Do you seriously? You were just like, oh, I got this notice. Oh, I don't want to do it. I'm going to leave today.
That was the straw. That was the last straw.
Oh, okay, yeah. Very good.
There were lots of other things.
It's like, it's just
that
such
was
a call.
the big one.
I don't like this. I'm going home.
I think for me it was more being my own boss part. I mean, certainly the mandatory Narcan prescription with opiates was clinically the thing that I was like, this really, I'm going to have to talk about Narcan, and that was. Is that just a California thing? I think so. Oh yeah, mandatory Narcan prescription with every opiate for all my chronic. I mean, anyway, so that was one straw. But I think For me, it was just the lack of autonomy. So my office manager, who was prior to being the office manager at my office at UCLA, was running the cafeteria, for a couple of years, and just had no, and so was refusing my vacation time requests and telling me I had minus 2 hours on my vacation time and they weren't going to improve it. For me, that was just the burnout moment where I realized I don't work for, who do I work for and what am I doing here? And so that was it.
On a serious note, I think for me, everybody in this room made a ton of sacrifice, and we were really, sadomasochistic in a way that we love to work and punish ourselves to be better people, going to medical school, residency, and doing all that. And at some moment, you realize, as a physician, the only way to be the best doctor you can be is by practicing in this way and caring for the patient and nobody else in the room. And I've heard this analogy a lot. It's just you and the patient. Nothing else matters at that point. And so DPC is, in my mind, the only way of doing that right now. Clearly, there could be other options in the future, but right now, this is it, and you get to own it, and you get to create what you want to create, and you get to be who you want to be, and that's just so amazing. So yeah, that's my moment.
So, So my moment was at a DPC conference, just like this one, and it was in Kansas City, actually. And there was so many stories and so much inspiration. I was in tears for part of the meeting. It was just mind-blowing to me, and I had just built this practice. I just started this fee-for-service practice. It was my baby. It was, had worked really hard on that, but I came home from that and said to my husband, that's it. This is what we're going to do. We're going to drop a bomb on the practice. Just blow it up. And so that was my moment. It's hearing all of your stories that inspired me.
Thank you guys so much. And I think, Lee, all right, I got the nod from Lee. If you guys have more questions, we are all here. And we are all available to answer questions. And the person sitting next to you also can answer your questions, because they're a good resource too. Thank you guys for your time. Thanks for listening.